Hi, I'm Tom Morris, one of the ED registrars, and I'm here to briefly talk you through the new NBT Epistaxis guideline. As part of ongoing aims to better manage epistaxis within the ED and improve patient flow, the Epistaxis guideline has been updated with the addition of a new stage for nasal packing, which we'll go through shortly. Patients with epistaxis should be approached in an A to E fashion with careful assessment to identify the site of bleeding. The majority of these are anterior nosebleeds from Little's area, found on the inside wall of the nasal septum. A small proportion of these bleeds can be posterior, which can present with bilateral nasal bleeding, failure to respond to first-line measures, and ongoing bleeding seen at the back of the throat. Remember, if any concerns about large amounts of blood loss, risk of airway compromise from the bleeding, or the patient is unwell or hemodynamically compromised, move straight to rapid Rhino insertion and get help. First-line measures of the guideline involve sitting the patient forward, pinching the fleshy part of the nose, ensuring both nostrils are closed, and holding tightly for 20 minutes. Some patients arriving via ambulance may already have a nasal clip on. Encourage the patient to spit out any blood, and if possible, the patient can suck on ice or have some placed at the back of the neck to aid vasoconstriction. Second line measures are nasal cautery. This involves following the identification of a likely bleeding point in the anterior nose. Silver nitrate sticks are used to cauterize the bleeding point. It is vital that at this step, the use of a vasoconstrictor is employed to allow a better view. In the department, we have cophenolcaine, found in the minus drug cupboard. This is a combination of lidocaine and phenylephrine. Following its application to the bleeding sites, it can cause local anaesthesia for cautery, but also importantly, it can stem the bleeding, allowing more effective cautery. Cophenolcaine comes in blue plastic boxes, complete with a spray applicator. First, ask the patient to blow their nose to remove any clots. If the bleeding is heavy, cophenolcaine can be soaked in some gauze and applied directly to the bleeding area using some forceps from the ENT trolley. Use the spray or apply directly with forceps to the suspected bleeding area and wait for the local anaesthetic action to have effect. Once this is complete, visualise the area and look for a bleeding spot. This can be a small red dot or could still be gently oozing. Take a silver nitrate stick and apply to the bleeding site for 3 to 10 seconds till a grey-white colour develops. Ensure you never cauterize the same area repeatedly or both sides of the septum to avoid perforating the septum. Remove any excess blood or chemical with a cotton bud and ensure liberal application of Naseptin antiseptic cream. See the guideline for more details. The next new step in the guideline is the use of Nasopore nasal packing. This is a biodegradable packing medium which, if successful, means these patients can be managed in an ambulatory fashion via ENT clinic. This should be taken if cautery fails and bleeding is ongoing. However, as previously mentioned, if the patient becomes unwell, shows large amounts of blood loss, there is a risk of airway compromise from bleeding or hemodynamically compromised, move straight to rapid Rhino insertion and get some help. So first off, you're going to want to ensure that the patient remains anaesthetised and that they've blown out clots from the affected side. You're going to want to load your Nasopore onto your Tilly's forceps. Nasopore is best mounted as shown in this picture, as it allows the wide front edge of Nasopore to get in through the nares. Then using your nasal speculum, you're going to open up the nair from which they're bleeding from, and you're going to gently insert the Nasopore along the floor of the nose, making sure it just sits just inside and abuts the septum side which is bleeding. You want to watch that now for 15 minutes, check the back of the throat and make sure that bleeding is resolved before discussing with the ENT. These patients may be able to be discharged from the ED with the Nasopore in and to be seen in ENT clinic at BRI after discussion with the ENT SHO. If the previous steps fail and the bleeding is ongoing, proceed to rapid Rhino insertion. Gather your equipment including rapid Rhinos, a large bowl with water and a 10ml syringe. Consent the patient and ensure they know that this will be an uncomfortable procedure and consider giving some analgesia. Soak the rapid Rhino in water for 30 seconds before passing it manually along the floor of the nose till the pack is fully inserted, noting none of it should be outside the nares. Slowly inflate the balloon with 5 to 10 mils of air and take the butterfly to the patient's cheeks. Reassess the patient, ensuring there is still no ongoing bleeding. If there is, consider a second rapid Rhino into the other nostril, and don't forget to check at the back of the throat following this insertion. As seen on screen, there is a summary flowchart as part of the guideline. Remember, the ENT trolley can be found in minors with the guideline inside it. The guideline can also be found on Eolus. please spread the word, help colleagues, and if you have any questions, get in touch at tom.morris@nbt.nhs.uk. Thank you very much.